Welcome to the Radiologist's Guide to ICI Toxicities, where we decode immune-related adverse events, or IRAEs, on restaging scans. IRAEs present a paradox. They signify an aggressive anti-tumor response, yet they require careful management. Early detection through imaging is crucial for mitigating adverse events without prematurely stopping life-extending immunotherapy. The radiologist plays a key role, particularly in identifying grade 1 toxicities, which are asymptomatic and imaging only. Early detection is vital, as increasing grades necessitate more drastic action, like high-dose steroids or therapy discontinuation. Thoracic IRAEs are common, with pneumonitis presenting in several patterns. Organizing pneumonia is the most common, characterized by the atoll sign. Other forms include nonspecific interstitial pneumonia, with peripheral reticulations, and acute interstitial pneumonitis, which shows an apicobasal gradient. Hypersensitivity pneumonitis, accounting for up to 22% of cases, typically presents as centrolobular nodules and ground glass opacities. This pattern is often associated with milder symptoms and a better prognosis. Other thoracic IRAEs include sarcoidosis-like reactions marked by symmetrical mediastinal and hilar lymphadenopathy. Radiation recall pneumonitis is confined to a previously radiated field and involves new ground glass opacities or organizing pneumonia. Cardiovascular IRAEs include myocarditis, a high mortality event best diagnosed with cardiac MRI. We also look for pericardial disease, such as tamponade, identified by right ventricular collapse and septal bowing on court. Gastrointestinal IRAEs primarily manifest as colitis. Diffuse colitis involves long segments of colon with severe wall thickening. Segmental colitis is localized, often associated with pre-existing diverticulosis, and may require antibiotics in addition to steroids. Hepatobiliary IRAEs include immune-mediated hepatitis, characterized by hepatomegaly and periportal edema on CT or MRI. Immune-mediated cholangitis is marked by diffusely thickened and enhancing bile duct walls. Immune-mediated pancreatitis can be diffuse or focal. Diffuse presentation shows bulky pancreas enlargement and peripancreatic fat stranding, while the focal type features segmental hypoenhancement. Hypophysitis is the main endocrine IRAE. MRI criteria include diffuse enlargement of the pituitary gland and absence of the normal posterior pituitary bright spot on T1 weighting. Other endocrine IRAEs include thyroiditis, which follows a biphasic timeline, and adrenalitis, presenting as smooth, uniform enlargement of the adrenal glands. Adrenalitis poses a clinical risk for hypovolemic or adrenal crisis. Musculoskeletal IRAEs often involve inflammatory arthritis with symmetrical joint involvement. CNS IRAEs, such as toxic encephalopathy, show prominent hyperintensity on flare sequences in the subcortical and periventricular white matter. Reviewing the chronology of toxicity reveals a varied timeline, with thyroiditis and colitis often appearing early, followed by hypophysitis, pancreatitis, and inflammatory arthritis months later. Finally, utilizing the correct imaging modality is key. Routine restaging CT targets pulmonary, gastrointestinal, and some hepatic IRAEs. Dedicated MRI is essential for hypophysitis, encephalopathy, and myocarditis. PET-CT is useful for sarcoidosis-like reactions and inflammatory arthritis. While single-organ toxicity is common, multi-organ IRAEs occur in 5.4 to 9.3% of patients. The paradox is that patients with multi-organ toxicities have a 42% response rate and a 53% reduced likelihood of death.